they value what you have bringing into the conversation and care. So it's not a paternalistic way of, I am going to do this, you are going to do that. It's what can we do together? What goals does the patient have for their birth experience? What I can provide to enhance that birth experience so that we can come together and not only give you a good outcome, but a beautiful birth experience.
Giving birth is one of the most significant events of your life. Sadly, the joy that you should feel can often be replaced with anxiety and helplessness instead. As a labor and delivery nurse, I'm revealing insider information to educate you, reassure you, and decrease your fear. In this podcast, you'll hear empowering birth stories and experts weigh in on a range of topics. Being Jewish also has me exploring Judaism's influence on the reproductive experience. However, I speak to anyone wishing to navigate their journey with more joy and confidence. I'm your host, Chani Fingerer, and you're listening to the Happy Birthway Podcast. It takes time and practice to master the skill of the newborn swaddle. So here's my hack. Go to elliesandco.com. Among their full line of gorgeous, high-quality baby bedding and layette sets, you will find adjustable swaddle blankets that take out all the guesswork. With a pocket for baby's legs and adjustable wings with secure closures, your baby's swaddle will be perfect every time. Go to elliesandco.com. That's ELYSANDCO.com and enter BW10 for 10% off your purchase. Link in the episode show notes. The Jewish weekly day of rest, Shabbos, is so precious and sacred. However, many women find it challenging to refrain from applying makeup on this festive day, and some are even hesitant to leave the house. Enter Seventh Day Shine, a revolutionary skincare and makeup line that can be applied on Shabbos while keeping halacha. Their foundation, blush, bronzer, eyeshadow, and eyeliner and lip powders come in a huge array of colors, and their application brushes are so luxurious. My favorite product is Luminosity, an intensely hydrating and refreshingly scented serum that's especially formulated for permissible application on Shabbos. Check out their full line on seventhDayShine.com. That's the number 7, THDAYSHINE.com and enter Birthway10 for 10% off your purchase. Find the link in the episode show notes. Welcome to another episode of the Happy Birthway Podcast. Today, I am so excited to interview Pamela Hetrick, a certified nurse midwife in a suburb of Cleveland, Ohio, for the past 18 years. She has been in the birth world for about 25 years. She also owns a consulting company at Hetrick Consulting, LLC, providing expert witnessing consultation for both sides of the fence, plaintiff and defense. She is also known as the Fairy Midmother on Instagram, and that is actually where I found Pamela. Welcome to the show, Pamela.
Well, thanks so much for having me. I'm very excited to be here today.
I'm so excited to have you, and I'm so excited to glean from your wisdom. I have so much respect for you and your amazing breadth of knowledge. The time that you must put into your Instagram posts is, I can tell that you put in a lot of time. You have such pearls of wisdom. I'm always learning from you, and I'm really excited about the conversation that we're going to have today around shared decision making, because you give so much information, which I think is a huge part of shared decision making. Before we start tackling our topic, I'm just curious, you living in Cleveland, Ohio, have you had any exposure to treating Orthodox Jewish women at all?
We have a big population of Orthodox Jewish women, so they have followed me from another institution that was much bigger, and they have followed us to a small community hospital because we are not far from a rabbinical college. So it works out perfect that we get all of the young new families, and then when they grow up and they're done with their schooling and they move a little bit farther south, we're still seeing them. So they're fun to work with.
That's fantastic. That's amazing. And we call that continuity of care, right, in our language, which we can also talk about. Jewish communities tend to be very clustered in specific areas just because of our kosher needs, because of the communal worship needs. So when I found out that you lived in Cleveland, Ohio, I suspected as much. And I wonder what it's like for you just learning more. I'm sure you've learned a ton from your, from your patients, but it would be so interesting for me to hear if you've learned any more when you see the things that I put out there.
You know what? It's funny because the other midwife that I work with, um, she is Jewish, but she always laughs because if there's anything coming up with Jewish holiday or whatever, she'll say, "Oh, I'm sorry. Hold on a second. Let me go ask Pam." And she will come to me and she's like, "These patients really honestly do think you're Jewish." And I'm like, "Well, you know what? I mean, I learn a lot. I have learned a lot from your podcast, or not. I'm sorry, not from the podcast, from your Instagram. I'll go back and say, 'Hey, do you know what this means?'" And she'll say, "Where do you learn this stuff from?" Well, I read it. But I think it gives us a better connection too on how to best care for your culture, is to be immersed in what your beliefs are and how we can best support it in the office and in the hospital.
That's so amazing that your Jewish patients get that culturally sensitive care, which again is a huge part of shared decision making. And thank you. Thank you for learning. And myself having my own unique cultural needs makes me more sensitive in my practice to honor others' unique cultural needs, be they religious, be they just through heritage and through upbringing. If they come from a certain culture, a different country, if they're, emigres from somewhere else. So that has really inform my practice. So thank you so much for providing such great culturally sensitive care. I also love the fact that we both connected over both being nurse expert witnesses, where we opine, we give our opinion to lawyers, to attorneys on birth injury. I mean, for the most part, birth injury cases. There can be other medical malpractice cases with, the mom too. We kind of look at all of the records, we put the story together, and we see if, in our opinion, if we were the same professional practicing, if we would have done the same, or if there's anything that was missed and that the standard of care was not upheld how it should have been, and which would have been which would have been what could have led to the damage.
Absolutely. And I think it makes, like, I love reviewing cases because I think it makes me a better practitioner. It makes me think globally. It makes me think differently on how I would counsel a patient, which I think goes into, our topic today of shared decision making, that, you're retrospectively looking at what was done, but it also makes you grow as a practitioner on how to provide the best care to the patient, whether it's counseling, whether it's hands-on technical, or collaborating with other healthcare providers. Absolutely.
I so very much agree with you. With every case that I review, it really makes me reflect back on my practice and just to make sure that I'm fully meeting every single little crevice, every single tiny little crevice of care. And no matter how any situation looks, making sure that I uphold the gold standard of care and really go way beyond. And yes, just those reminders, the standards of care and best practices really, really, really improves my practice as well. So that was great to bond over that too.
And to have somebody to be able to send, send you an RN case if it comes up, because I do some registered nurse review, but sometimes depending on the damages, they want somebody that's actually working and physically at the bedside with the patient. So it's always good to collaborate. And I cannot believe how many people I've collaborated over Instagram. So it's just been a plethora of knowledge that I've got from this whole fairy mid-mother experience.
Social media is so unique and such a new frontier, and there are definitely detrimental things about it, but on the other side, there are so many beautiful, beneficial things like us meeting. And yes, like you said, with sending to RNs, when it comes to my work, I only can give my opinion on specifically the area of practice that I myself practice in. So, like, I'm not an obstetrician or a midwife. I'm not a nurse that works in an office. I'm a nurse that works at the bedside on labor delivery or postpartum or newborn care, and that's the only place that I can give my opinion. And also during the time that the actual event happened. So it can't be that I was only practicing after the event happened, because our practice changes constantly as we receive more and more evidence, more data, research, and information. So, and that leads us into shared decision making. Let's go back to the basics. And can you give us a definition exactly of what shared decision making is?
So shared decision making is when your provider that is taking care of you, or your bedside nurse, think of anybody who is in that taking care of you mode, and they value what you have bringing into the conversation and bringing into care. So it's not like a paternalistic way of, I am going to do this, you are going to do that. It's what can we do together? It's what goals does the patient have for their, birth experience. It's what I can provide to enhance that birth experience so that we can come together and not only give you a good outcome, but a beautiful birth experience too. And as we go on in the conversation, there's other things called guided discovery that happens in shared decision making, where there might be a little bump in the road, say your blood pressures or the fetal heart rate tracing, or something that we weren't necessarily expecting to happen, but it happens, and then we revisit the whole plan there. So you feel like, the patient feels like they're empowered in their care.
It's been found through research that the model of shared decision-making care has been a huge factor in patient satisfaction experiences. And a lot of the birth trauma that people experience from their birth is largely based on the fact that they were not given options. They were not informed about why something was done to them or being recommended, and later on came out with doubts or felt like their autonomy was disrespected. So, and going back to legal, we know that the more a patient is informed and the more that they're involved in helping to make the decisions in healthcare that are best for them, the less likely they are to pursue legal action, because they feel like they share ownership in their healthcare, and they are completely informed about their situation, and their satisfaction is a lot higher. So they're less likely to question and wonder whether something was missed and something wasn't done appropriately.
I completely agree. And the part that I always think about is the patients who, maybe didn't have the best birth experience, and, they want something new. So all of a sudden, here comes, a patient in our office that it's their third baby or their fourth baby, and they've had physicians for all their births. And now all of a sudden, boom, they're in a midwife's office, and you're like, oh, well, tell me a little bit more about, what made you want to come see a midwife? Were you plopped on my schedule just because I had an opening and it was great time with an ultrasound, or is there a reason that you're seeking out midwifery care? And it usually is because they had a disgruntlement with not being told options or being told what they were going to do. And so the very funny thing about when you take care of a woman that's had that experience is, if all of a sudden you start giving them options like, well, you could do this, and this is the reason why, and this is another option, this is another option, what do you think? Sometimes the patients have told us that they get very overwhelmed because, it's the quote unquote adulting part of the decision making. Like, oh my gosh, nobody's ever asked me this before. Like, you mean I get to pick? Yeah, because you know what? You need to feel like this is a good decision for you and your baby. And that's a part of midwifery care that I love, is when the patient all of a sudden feels like you are really vested into knowing the standard of care, knowing what the evidence shows, and you're giving the power back to the patient to decide what's the best for them and their family.
So often, I think that the patient would have had the identical care, possibly, with a shared decision-making model and just being told what to do, but their experience, they probably would choose the same exact thing, but their experience of having ownership in their care and feeling like they have bodily autonomy and agency over their situation completely changes the landscape and their experience.
And I'll agree with that. And I will also say, I think that when you build that trust, and when the patient knows that you have their their best experience and their best birth outcome at heart, that if something needs to change quickly, like, we weren't expecting to have a C-section and it's your fourth baby. However, this is what the baby is showing us. The baby needs to be born sooner or later. The trust then goes with that. They morphed with the plan and they went with it, knowing that we have the best, yeah, their well-being and the best interests of mom and baby. And I always say to patients, 88% of our patients are going to walk out of here with a vaginal birth. So if you're within that 12%, you really do need it. We don't do C-sections just because it's 10 o'clock at night or our kids have a soccer game. We do C-sections when, maternally or fetally indicated. And I think that when you gain the trust of the patient, changes to the course of the management of labor and birth, they become a little bit more, I don't want to say lenient, but understanding that we're going back to do what's best for mom and baby.
I think it's easier to accept an unexpected outcome or bump in the road. I think it's easier to have that acceptance. And I tell that to my patients when we encounter that situation in the hospital. I say to them, listen, you're using a provider that has tried everything to get you the outcome that you want. And if they are saying that you need a specific intervention that you were hoping not to have, it is truly because you need it, and you can have it without doubts, knowing that nobody's perfect, but that we're making the best decision we can with the knowledge that we have.
Absolutely. So part of shared decision making that I love is, some people or some institutions, some providers will say, "Oh, the patient has a birth plan. That's an automatic, C-section," and that's totally not true. Totally not true. It's your preferences, and so it's funny because on the weekends we share call with four of our female obstetricians, and the one came out and said, "Oh, I love birth plans because you know why? You can sit there with the patient and look at the birth plan and know realistically if we're able to give the patient what they want. And also, it's a great time if you have a patient that says, I don't want an IV, I don't want IV access, is to talk a little bit more in depth about, okay, ultimately, I can't force you to have a saline lock or IV access, but let me tell you about why we recommend them." And then it puts it back in the patient's lap to say, "Okay, you know what? Nobody ever explained it to me like that. I didn't think about it like that. I'm totally fine with it." So it kind of takes down those barriers of what people get upset about on labor and delivery when they're told no, without really understanding why the recommendation is there to do A, B, C, or D.
Oh my gosh, yes. And that is exactly, you couldn't have said it better. That is exactly what I believe and what I stand for and why I do what I do. I find it just completely changes a patient's attitude about something. And I think it's so important to start going over this birth plan way early into your pregnancy. Even first trimester is not too early to start the conversation, because you are still kind of discovering what your preferences may be. And you are also learning early on what is actually possible to meet with your preferences, because there are some things that are just physically not possible. For example, if you want to be able to shower during your labor, use the shower for comfort measures during your labor, but the hospital you're giving birth at doesn't have showers in the bathroom, you won't be able to have that. And so often I have patients that come in disappointed because they wanted something that now they learn that they can't get so late on. And this was a vision that they had for so many months. Come to find out that they can't get it. And it's so disappointing. And that's why I believe so much in the importance of having the conversation weeks and weeks in advance of your birth, so that you can actually have realistic expectations that will less likely lead to disappointment.
Absolutely. Absolutely. And it's, the other thing is just a little reminder is, for everybody out there who is pregnant or thinking about becoming pregnant, sometimes hospitals will advertise that they have X, Y, and Z, and let's just bring up the birthing tub because it always seems to come up. Well, in some institutions, some providers don't, quote unquote, like the birthing tub. So yes, they might have it at that facility, but it's so important to ask the provider and to put down in writing so you can both sit there and come up with the best plan, that yes, your facility might have water labor capability, but your provider doesn't allow it. That also gives you enough time to think about a different provider for your birth, with bringing that up early. And I would say around the 20-ish week point, where you start to feel better, you're starting to think about birth, you're halfway there, because, this only happens once in your life. And to be told when you're walking into the hospital that, no, you can't do this, you might say to yourself, oh my gosh, if I would have known about this, I would have never continued with this certain individual. And so it gives you enough time to transfer to somebody else that aligns better with what your vision is.
Oh, yes, such sage words. And even if your hospital does have bathtubs and your providers on board, it's always also important to know that maybe where I work, every single room has a tub except for one room. And if you get unlucky and you come to the hospital on the day that every single room is occupied except for that room, because we do occupy that room last, then unfortunately you're going to be out of luck. Or the same thing where we used to have only one remote monitor. So if someone else is using that monitor, then you may be attached to wires and you may not be able to move around as you wished to have done so, because unfortunately that's just something we can't, it's a limitation. So yes, these are all such incredible, important things to bring up. And also, we know that some people are limited in the providers that they can use, either be it health insurance limitations or location limitations. And I recently interviewed someone who had one of those limitations, and she knew that she would be using a provider that she may not have seen exactly eye to eye with in certain things, but she prepared herself ahead of time to know how she would handle potential hiccups in her plan. Like, she wanted to go unmedicated, and her provider was kind of not, very lukewarm and not being the most supportive about it. So she prepared herself as to how she would navigate that in the hospital if she were to start being pressured into getting pain medication that she didn't want to have. So I think that that's also just something else you can do, something else that's within your control if you can't actually switch to another provider.
Absolutely. Those are all really, really good points and things that happen more than what you think, basically.
Yeah. So flexibility is important, but it's also really important to establish what your preferences are, to educate yourself on what your options are, right? So, how does a shared decision making model play out?
So it should start at the first prenatal visit, is that you are also asking the patient what their goals are for the pregnancy. And, depending, you might need to revisit this depending if you are meeting with a mom and they're feeling their first trimester absolutely worse. Talking about weight gain and other things might not be pertinent, but other things, comfort measures with nausea and fatigue might play, more of a role at that visit. And you kind of morph. I mean, there's certain things that we need to definitely go over and educate on and the whys of why we recommend things or don't recommend things. But you kind of have to gauge it too with how the patient's feeling at that appointment. And telling them, we'll talk about this, but let's get through the first 12 weeks of getting you back on your feet. So, shared decision making is giving the patient options, making sure that they understand the evidence of why you are recommending this. Weight gain is always a super sensitive subject. And so trying to be cognizant of, nobody wants to be fat shamed and nobody wants to think that you are completely just focused on their weight. However, I think it's super important too that patients understand why we're concerned, what increased risks that you have. And so that's one thing that I will toot midwives' horns right now, is that we do a super good job on trying to reduce risks for healthy birth outcomes. So, shared decision making, we go through the pregnancy, we flex when we have to. So we do that guided discovery. Most of the time in a midwife's, under our care, the first bump that we typically hit is diabetes. And so we have to do a lot of guided discovery, especially for the patient who was planning a home birth and is now diabetic, or somebody that is diabetic and their fastings are elevated, and we know that insulin um, is going to be recommended next. And so we have to flex with how birth is going to look different than what they anticipated, and we keep building on that until we get mom and baby together after birth.
So, going back a few things, because I'm also plugging midwives, I think they're phenomenal. Can we just quickly have an overview as to what a midwife is? Because I've spoken to people who are under the impression that if you use a midwife, firstly, that a midwife is the same thing as a doula. Secondly, that if you use a midwife, then you can't have a lot of interventions. You can't get an epidural. You have to do everything completely intervention free. And also that there's another misconception that midwives are not so educated and they're not so qualified. And if something turns high risk, then they're just not going to get good care from a midwife. So can we go back? Can you quickly just give us in a nutshell, your training and your scope of practice?
Sure. So I will say the one thing is I will agree with you that people think that A, you can't have an epidural, and B, that you have to have a home birth. And, midwives are regulated from state to state. And so, for example, in Ohio, the only type of midwifery that is recognized by the state of Ohio is a certified nurse midwife, which means that in a previous life, we were a nurse. Most of us did work on labor and delivery, and then we went back to graduate school, and which is a 2 to 3 year program, and we all sit for a national board, so we're all taking the same test, and then we become licensed within our state as a certified nurse midwife. So I report to a board, which is the Ohio Board of Nursing, and I have to uphold standards. And if I don't uphold those standards, I can be reprimanded through the state of Ohio. Some states, I know Jersey, New York, Florida, um, some midwives who are not, uh, they're certified midwives.
But they didn't become a nurse first.
They did not become a nurse first.
They just have like an undergrad in science, I think science prerequisites, and then they go straight to a master's in midwifery, where I do believe that they learn the same things as a certified nurse midwife. They don't have the nursing component and potentially not the nurse, well, not potentially, they don't have the nursing experience that actually a lot of certified nurse midwives have to have even before they can qualify to attend a CNM program, but I think that they do need to take the same board certification as a certified nurse midwife does before they qualify, right?
So certified midwives also take a national exam, and in some states, both certified nurse midwives and certified midwives are actually governed through the Department of Health. So they kind of set the standards of what we can take care of and what we should be referring to a physician.
And then there's a third type of midwife, which is a CPM, which is a certified professional midwife. Their training is a little bit different. It's more like apprenticeship based, and they are, I believe, in the entire United States. They practice in the community. They practice in doing home births and birth center births, but to my knowledge, they don't do hospital births.
I think you are absolutely correct with that. And in certain states also, a CPM would also be lumped into a midwife category for the Department of Health and with written guidelines, which I personally feel like every state should adopt that, because doesn't every woman deserve to have somebody that has set standards on when referral and transfer is best? And that is the super hard thing in Ohio, because since only a certified nurse midwife is recognized, means that we have CM, CPMs, direct entry midwives that are out strictly doing home birth on patients that might not be appropriate. And so it's one of the things that, we're trying to change, but it is very, very important for a woman to ask what your training was, and to dig deep down into their statistics too, and their philosophy of care for you to have a safe outcome.
100%. You couldn't have said it better. And it really does affect the quality of care that women can get when only CNMs are supervised and held to a certain standard. Whereas when women are seeking care from a different kind of midwife, they don't know that they're getting that quality of care. It definitely is a hindrance. So much agreed. And unfortunately, I've had patients who thankfully came to the hospital because they needed a hospital birth when they were originally planning a home birth. But it was upsetting because, like you said, they had very obvious medical complications in their pregnancy that were not addressed and that actually affected the outcome. Like, for example, I had a patient who had diabetes and was receiving care from a midwife that I'm not sure what the rules are in Connecticut, but this particular midwife who was, I don't know if she was a CPM or, some kind of apprenticeship-based midwife, but this patient never got tested for diabetes, and the patient didn't even understand what the importance was of getting tested for diabetes. We don't know for sure if she had diabetes or not, but when she had such a large baby that was 11 and a half pounds, she ended up unfortunately having to have a C-section. And who knows if she would have gotten tested and found to have diabetes and would have intervened appropriately to control it. Who knows if she may have been able to have a vaginal birth. So definitely it affects the quality of care and can affect the outcomes and can make them worse than really they could be. And especially this happens to people who have had a negative experience in the past with the medical care system. And when someone comes and is giving them so many options and is so nurturing and kind, it's easy to just forget that they also need to have the proper qualifications to be able to care for you safely.
Right. And talking about the patient that you just referenced, let's just take, for example, that we have somebody that didn't get the screening done and is diabetic and does have a home birth and did have a vaginal delivery. The care of the baby afterwards is so different, and the risk of the baby becoming severely hypoglycemic that can affect brain function and a lot of other systems in a baby's body is a little bit more monitored. So yes, that's another great shared decision making little pearl, is that we talk about that. If you are diagnosed with diabetes in the pregnancy, is not only what is the care going to be a little bit different for you as the mom, but also how important it is to prevent hypoglycemia in the baby.
Yes, so very much. And that baby, because of that baby's size, needed to receive a very similar type of care as a baby whose mom would have had diabetes anyway, because the baby was so large. So thankfully, the baby did receive good care. And needless to say, Pamela, you definitely sound like you're medically qualified, unlike a lot of the presumptions that people have about midwives. So as we've established, certified nurse midwives have a very well-rounded, thorough training in caring for a woman, anyone pregnant, and just well woman care throughout the entire reproductive and menopausal, perimenopausal cycle of life. Many gynecological procedures you can perform, such as IUD insertion and doing pap smears, and you're in the same category as an advanced nurse practitioner. So kind of a parallel to that. Plus, you can also attend deliveries, and basically, I like to say the only limits at a birth for a certified nurse midwife is doing a vacuum or forceps extraction, or episiotomies you can do, right?
We do episiotomies. It's just if it's a third or fourth degree tear or an episiotomy extension, we call a backup physician in for them to repair that detailed of a tear. But you're absolutely correct. That's the other thing is, people think that midwives only are, I don't want to say only are interested in catching babies, but we like to say that we're there for women from the womb to the tomb. So, we can see, we see younger females that maybe have some menstrual problems or some vaginal irritation problems, all the way to our ladies in the nursing home. Which I at my current position, I also have participated in the house calls house calls program. So I've actually gone into long-term care facilities to address some issues. So it's really well-rounded what we do, and for those of us who have had a plethora of years of experience, we basically manage a lot of things until the time of a referral for surgery.
Midwifery care, as you had briefly touched upon, very much focuses on the holistic care where you're looking at an entire picture. Like you said, you had used a word for it, guided discovery.
Guided discovery, yep.
Guided discovery, where you're trying to fit in the care into all of the parts of their life circumstances, their life setup, their personal perceptions, their personal priorities, goals, and values, right? Which is so very much the foundation of shared decision making.
I completely agree.
So let's talk about informed consent, because we all know that that is like a huge part of shared decision making. Can you briefly go over what that really is?
In obstetrics, it is literally impossible for us to consent for every little thing that can go wrong. We don't consent for a shoulder dystocia, or do informed consent for a shoulder dystocia where the baby's shoulder gets stuck under the pubic bone, or a prolapse of the umbilical cord. But informed consent goes with how I put it before, is that 88% of our patients walk out of here with a vaginal birth, but 12% of women do get a C-section for, and we go through, whether their baby is breech, or there is a arrest of labor where labor just kind of stalls and doesn't progress forward. And, informed consent is when the plan of care changes and you are advising for induction or augmentation, tweaking the labor a little bit with what those risks involve. What's the benefits? We'll talk about Pitocin. That comes up quite frequently on birth plans, that people don't want Pitocin, but really some of those interventions can actually increase your success of a vaginal birth should, your water break and you don't go into labor, or your contractions kind of fizzle out because you're exhausted and tired, and you're worn out. So, bringing interventions in. Informed consent is saying, we could do nothing, but this is what the recommendations would be a C-section if your cervix doesn't change in 6 hours, or we can start some Pitocin, and these are the risks and the benefits of that, and have the patient decide. That's true informed consent, is that the patient understands risks, benefits, alternatives to what you're recommending.
Yes, and a common acronym for that is BRAIN. So the B is for benefits, the R is for risks, the A is for are there any alternatives, the I is for your own gut intuition because you know yourself best, and the N is what would happen if we did nothing, or if we can have some extra time. Do we have a little bit of extra time to decide and figure out a plan of care? So, and like you said, I think we also have to walk the balance of not informing a patient of every last scenario that can go wrong, because we also don't want to give them the fear. So it's a balance. And I hear sometimes from people who tell me that they felt uncomfortable because they were told all of these scary things that can go wrong in their particular medical condition, and it's scary for them. So I do think that there's really a balance that we need to walk. Some people say that their perception of the information they got was that if they don't do XYZ, their baby will die or they will die. And it's so much more layered than that. And it's so important for us to present the information in a way that's not going to alarm the patient, right? Do you find that challenging?
I do. That actually, I did an Instagram live on Friday about, increased risks. I did it for Black Maternal Health Week, and or Awareness Week, and because I just had a recent conversation with a patient who is on baby number 12 and has developed some risk factors, and of course is older than she was when she's had her other 11 children. And her response to me was, "Why are you trying to scare me?" I said, "I'm not trying to scare you. I'm just trying to let you know, these are preventable or modifiable risk factors that you have." And so my goal of telling her, recommendations of a baby aspirin and trying to do minimal weight gain is basically for her to not develop the hypertensive issues that she had after her last birth. But sometimes it comes across as, "You're scaring me," but then on my end, I don't want it to be, "You never told me." So there is that fine balance. And what a great thing is that if you're concerned, you ask your provider, "Do you have any literature from any governing body that backs up what you're talking about?" Because sometimes patients just, they don't know. And when they read the literature and it's what their practitioner is advising, it becomes a little bit more that the provider has power behind. I don't want to say power, but they get
Credibility.
credibility, right? They get credibility that they're following evidence-based care.
It really is. I find that very challenging, to maintaining the transparency and people knowing about their body and their medical conditions, which again is important for autonomy, a person's autonomy, but at the same time not alarming them so much. And I believe that it also is something that you learn in the guided discovery, where you figure out just how much someone really wants to know. I have a friend whose son has cancer, and her attitude was don't talk to me about any possible scenarios, even if you think that they're going to happen. She said, I trust my medical team to do it when it's actually necessary. And she told them this, like she would say to them, does he need to be intubated right now? And they would say no, but then don't talk to me about it right now. When you need to do it, you do it, and I fully trust you. So I think that there really are different attitudes that people have. And she did get some judgment from the hospital workers, the healthcare workers. And to me, it really opened my eyes because it allowed me to have less judgment on patients that really didn't want to know. Because we have to follow their lead too. And if it's going to overwhelm them with anxiety and cripple them, then it may not be in their best interest, right?
Right, absolutely. Speaking of guided discovery and echoing off your friend's thought process, if I think, just say I check somebody now and we've been stuck at 7 centimeters for a couple hours, and it's a patient that that the word C-section is going to be upsetting, I always will say, okay, I like to think out loud. And so I'm going to tell you what my thoughts are, because I don't want to come in here in 2 hours and be like, whoop, that's it. You have to have a C-section. I kind of want to give them enough information so they feel like, again, they're a part of the decision-making process. But I would never do it as a scare tactic early on, but I want them to feel like they understand the process of why I'm recommending this, and they have time to ask questions.
Yes, it's so nuanced. You're so right. Like you said, when someone's not dilating for a long time and it's not an urgent or emergent situation at that moment, but we see that it may turn into that, we look at it as, you know what, it's better to start the conversation sooner just so that they have time to digest that outcome instead of just shocking them. So yeah, it's so nuanced, and it's really walking that balance, and it sounds like you're so skilled at it. It's amazing. Sometimes I see though that there are patients that just don't want to have the burden and responsibility of making the decisions for themselves, and they just want someone to just tell them what to do. Do you have that? Do you have someone saying to you, well, if it were you, what would you do? And how do you respond to that?
So I squirm a little bit when they ask me that. You know what I mean? I'm like, oh, or the other funny thing is if I know that something truly is in the best interest of this mom or baby, I'll start out in my brain, and it comes out of my mouth. I'll start with giving all of the options, and then I'll stop for a second. I'll say, do you just want me to give it to you straight? And most of the patients, I would say 98%, will start laughing, and they're like, what would you do? So I'm like, this is what I would.
Because they trust you.
Exactly. And they know that I am a straight shooter. I'm not going to sugarcoat stuff if it needs to be sugarcoated, and that's where sometimes I'll start with the sugarcoating, and I'm like, Pam, what are you thinking right now? Just give it to, you know what I mean? Like, this might come across as confusing. Just give it to them straight.
But you don't infantilize them and make them like children. You treat them like the adults that they deserve to be treated like.
Absolutely. Yep. So many of times I'll have patients say, I don't know, what would you do? And I'm like, I tell them what I would do. And most of the time there is that trust that you get, that deep trust that the patients typically will say, okay, well, that's what I want to do.
Yeah. I have that as in my personal practice. I like to take the, let's put it in air quotes, difficult patients, because it actually is a challenge I enjoy, where a nurse might hand off a patient and tell me that this patient has been having a lot of requests or being unreasonable about something and being combative. And then when I come in and put the patient in the driver's seat and start explaining things to the patient and taking off that pressure of a power struggle, they really just turn around. And then they almost immediately develop that trust that, oh, hey, there's reasons behind this. And pressure free, like, this is up to you, but this is why. And then I see when I'll start saying, oh, well, it's recommended to do this and that. Okay, sure. Do whatever you need. I never saw it that way. I never knew it was that way. Now I understand. So, yeah.
Yeah. You probably have when the charge nurse is like, ooh, this patient's kind of difficult. who should we assign this patient to? They probably call you in like, okay, she's all yours.
I've had a coworker that swapped patients with me. She gave me her, midwife patient that wanted to give birth on all fours. And she was like, I'll take your super high risk, medically complex patient over this any day. So I like the challenge. I enjoy it. And I think it's wonderful.
Absolutely.
I think it's wonderful that people are exercising their rights and are being assertive and advocating for themselves. So I really do enjoy it. And you are someone who has a very long-term relationship with patients. You don't just see them like myself for just a 12-hour shift and then never again, or maybe have them repeat in 2 years from now and they come to have their second baby. But you are someone who may see patients from the start of when they're in puberty all the way through having babies, right?
Yep. Yeah, the oldest babies that I've caught, I think, are about 19 or 20. I would have to look at my birth log, but that's like the next life adjusting moment. I always laugh because one of the obstetricians in our office, the patients will come in and say, "Oh, Dr. B delivered me, and now I'm having," and I'm like, "Oh my gosh, that makes him sound like really old." But I mean, the truth of the matter is I've probably got patients that I caught them at their birth as a newborn that are now in the reproductive stage of life. So it has been super rewarding. A lot of my patients that I have cared for when I was a brand new baby midwife back in 2004, come back every year and send me cards in the mail, and I get to see their families grow and um, develop these lifelong relationships with them. So that's been, I would say, probably the most rewarding part of my job. And that patients followed me from one practice to another practice. I think um, it's very heartwarming.
Yeah, that's so beautiful. And we call that continuity of care, where you're caring for this same patient for so long that you really know them well. You're always continuously discovering things about them, but that initial guided discovery part of it, you've really established well, and you know their medical conditions well. You've attended, potentially you've attended other births of their other babies and seen how their bodies reacted to it. And that is so valuable.
And when things are off. That's the part that is, you know when you walk into the room for their postpartum check, and and I usually say, "Hey, how's everything going? How's everyone adjusting with this new baby?" And when there's that patient pause and all of a sudden you look and you know that they're just on the brink of, I just get them a box of Kleenex and I'm like, "All right, tell me about it." But it's you know what the patient's baseline is, you know what their home situation is, you know if they have any anxiety or depression. There's ones that we're in contact with much more frequently than a 4-week postpartum check, but that's the one nice thing about the practice that I'm in, is that you really do get to know the patient and their family.
That's incredible. That is so incredible. So, our time is coming to a close, unfortunately, because you and I can go on for ages.
Yep.
And of course, I hope I can have you on again soon because there's so many more things to converse about. I want to end off this episode by asking you, what can you tell our listeners who are looking for a provider, be it a doctor or a midwife? Are there any questions that you think that patients can ask to really help them get an idea of how supportive their provider is in the shared decision-making model? Can they even ask the provider straight up, "Hey, what are your thoughts about shared decision-making?"
So I would tell anybody the first thing that they should do is get on Google, put that provider's name in, read their reviews. The other wealth of information that you can get is to call labor and delivery where you plan on giving birth at. If you know that you have to give birth at a certain institution because of your insurance or because of your medical needs, call up there and just ask them, "Hey, who would you recommend?" Those are the people that really know the ins and outs of that provider.
Oh, yes. You know how you know what I like to compare it to? My kids have a phenomenal dentist that is only pediatric dentist that I wish can be my dentist, but the dental hygienist that I work with over there, I ask them to recommend a good adult dentist. And because I know as a labor and delivery nurse, labor and delivery nurses are the best ones to ask about who a good provider is. They really see the ins and outs, the good, bad, and ugly. And you're so right. That is like amazing advice.
Yeah. Yeah. So I would use those two tools, but also I have developed a new OB tool that is going to be on my Instagram page probably this week for questions to ask. Like, as much as we interview the patient for stuff, the patient needs to interview us to make sure that this is a good fit. So
Yes.
keep asking questions, mommy groups, word of mouth. But the labor and delivery team is actually very good to ask too.
Wow. So that's really exciting. By the time this episode will be airing, that tool will be up already on your Instagram.
Yep.
And that's amazing. So, leading on to that, can you please tell us all the ways that someone can find you and can avail themselves of the amazing things that you have to offer?
So I do have an Instagram page called The Fairy Midmother, and Midmother is all one word. It started out to be more of how to help labor and delivery providers, bedside providers, but it's kind of morphed into what women in general need for labor and birth. And then I do not have a website, but my email address is my whole entire name, so Pamela Hetrick at iCloud.com. And I would, of course, I can't give any medical decision making, but I can very, very much would be happy to guide you in what you're looking for.
And I will put both of those into my show notes. So if anyone is looking for any guidance, insight, advice, well, like you said, not medical advice, unless they are living in the area and
Correct.
they are looking for an obstetric provider. I mean, Pamela is like, I can't imagine anyone better than you. So they can find you as well, right? Just
Yes.
putting in your name.
Putting in my name, I cover the east side of Cleveland, and yes, I would love to chat and meet people in person if you're in
Awesome.
Cleveland.
Anything else that any important message that you want to leave us off with?
The important message is if something doesn't feel right in your gut about your care, whether it's something that is referenced or something that was said or a vibe that you feel, go with that. And, a lot of times I'll hear from women like, oh, I feel really guilty that I'm leaving, this provider here or doctor, blah, blah, blah. And it's like, again, this is a once in a lifetime situation and memory. And I would hate for you to say, I regretted my decision of not transferring or not finding somebody that aligns with my vision and goals and, end up with PTSD from the birth or those regrets. So always trust your mommy gut. Always.
No one holds a greater stake in your health and well-being than you do. So much.
Absolutely.
Thanks again, Pamela.
You are very welcome.
Thanks for tuning into the Happy Birthway podcast. Head over to Yoledet Academy on Instagram to continue the conversation. You'll find the link in the episode show notes, as well as links to any additional resources, products, and services mentioned here. If you love listening to this show, you can help it grow by sharing it with your friends and rating and reviewing it. To stay in the loop when new episodes are released, make sure to subscribe. Remember that your health needs are unique and require individualized medical advice. The podcast is not a replacement, and some of the information may not be appropriate for your specific circumstances. My mission is to educate you so that you can confidently collaborate with your healthcare team. I believe that a healthy mom and healthy baby are simply not enough. We also need a happy mom with an empowering birth experience.